Professor Ganguly, my old friend, uh, chairman of the Gut Microbiota and Probiotic Science Foundation, um, Professor Yoshi Takeda, also my very old friend, special guest, distinguished organizing committee for this wonderful symposium at this absolutely stunningly beautiful university, honored guests, colleagues, delegates, and old friends. I have many old friends in Calcutta, and it's always a delight to be able to come here. Some months ago, Dr. Ganguly and Dr. Krishnaiyer and I were asked to present some information to the director of the Sero office of WHO in Delhi, some information about the use of oral cholera vaccine in the Rohingya refugees, which is quite a wonderful story that I won't be able to tell today, but it really allowed that refugee effort to dodge a bullet, namely cholera. And we celebrated the meeting in our typical fashion with drinks afterwards. And it was perhaps after too many drinks that Dr. Ganguly said, well, why don't you be the chief guest at the symposium on microbiota and probiotics. I was, of course, having had several drinks, delighted to accept. And it's been a very interesting opportunity for me as a non-specialist to try to catch up on this enormous and rapidly changing field and to ask a question that affects me directly as a vaccine guy, and particularly an oral cholera vaccine guy. Namely, how can we augment the protection by oral cholera vaccines, especially in children? Sorry about that. Actually, the talk is making a good vaccine better. Are there non-vaccine approaches to augmenting the protection by OCVs, especially in children? This shows the global burden of cholera, which kills about 100,000 people worldwide, half of whom die in Africa. But contrary to what many clinicians in India think, cholera is actually a very big problem in India. A very careful review by Professor Ganguly and Nair and Bhattacharya, Deepika Sur, Dr. Suman Kanungo, showed that India actually has the largest number of cases of cholera of any country in the world. Now, in part, of course, that's because India is such a large country, but it still is a major problem here. And it's not decreasing. These are time trend analyses reported by WHO, which, of course, underestimate the burden, but at least show that the trend continues. And it's going to continue even further because cholera is becoming an urban disease. Way back in the 1980s, when I started doing cholera studies, it was largely a rural disease, but it's moved into the cities, the rapidly expanding busties of places like Calcutta and Dhaka, creating huge outbreaks. This is a real-life photo of a recent cholera outbreak in Dhaka, in which we had to build a temporary tent outside of our hospital to take care of the 1,000 patients per day that we were seeing. Cholera is known to be temperature sensitive and is likely to increase with global warming and an increased frequency of El Nino events. And it certainly doesn't help that man-made natural disasters, such as the one currently in Yemen, which is experiencing the world's largest cholera outbreak, probably in the last century, is absolutely devastating. And man-made emergencies like the Rohingya refugee crisis in Cox's Bazar, Bangladesh. What about cholera vaccines? The first cholera vaccines date back to the 1880s, shortly after Robert Koch isolated the cholera bacillus from a patient with cholera. Interestingly, they were used for the next 80 years, given to millions of people without any proper evaluation in clinical trials until 1960s, when properly designed WHO-sponsored studies were done in East Pakistan, now Bangladesh, India, actually here in Calcutta, Philippines, and Indonesia, and found these injectable whole cell vaccines to be really quite worthless, inducing only transient protection at the cost of unacceptable side effects. And so in 1973, WHO succeeded in removing cholera vaccines from cholera control measures, and that was considered a public health triumph and greatly impeded the reintroduction many, many decades later of newer generation vaccines. But while this was happening, scientific understanding of what is natural immunity to cholera improved with the recognition that natural cholera infections are immunizing, that the basis is mucosal secretory antibodies, primarily directed against LPS, but also against the toxin. These two forms of immunity were demonstrated to act synergistically. And the most important recognition was that oral ingestion of antigens, rather than injection of antigens, was the most effective method of eliciting this kind of mucosal immunity. Following all that and a good deal of work, 3 inactivated whole cell-based oral cholera vaccines have been internationally licensed and WHO pre-qualified and approved for use. The first, as was mentioned by Dr. Takeda, was developed by Professor Jan Holmgren in Sweden, consisting of killed cholera whole cells and a B subunit of cholera toxin. It has the advantage of being safe and effective, the disadvantage of having to be administered with large volumes of buffer, which really impede use in the field, and is still a very expensive vaccine. And because of that expense, years ago, Professor Holmgren and I and others worked to improve a killed whole cell, inexpensive vaccine that had been actually produced in Vietnam with the help of Dr. Holmgren, but could not be internationally used because of the lack of a WHO-approved regulatory authority in Vietnam, as well as the lack of good manufacturing practices in vaccine production. It all ended up with the development of Shankal, which I presume you all know, produced by Shanta Biotechnics in Hyderabad, which is WHO pre-qualified and inexpensive. The same technology was transferred to a company in Korea called U Biologics, and an essentially identical vaccine is produced by them to increase the global supply. These newer generation vaccines have the advantage of not requiring a buffer to co-administer with vaccine, and can be simply administered by a syringe. This is actually a picture taken in Calcutta during a large field trial of this vaccine. And these are the results of that large field trial conducted or led by Sujit Bhattacharya and Deepika Sur and colleagues, and under the absolutely irreplaceable, essential support and guidance of Professor Ganguly, this vaccine, in a trial of about 60,000 people in the slums of this city, conferred 5-year protection of about 65%. Interestingly, protection in the 5th year was identical, was no lower than it was in the 1st year. So this is absolutely sustained 5-year protection. Additional work by Ira Longini at the University of Washington used these data to parameterize dynamic population-based models of cholera to demonstrate that the combination of direct protection and herd protection by this vaccine could extinguish cholera in a place like Matla, Bangladesh, which is hyper-endemic, with only 60% coverage. These vaccines have now been stockpiled by WHO in a global stockpile funded by Gavi, and have been deployed in, I guess, more than 25 million doses over the past several years. And these are simply results of studies of this vaccine deployed in these real-life epidemic and endemic situations, showing very high levels of protection. So all of this prompted a science writer for the New York Times, Donald McNeil, to write, it was actually a front page article last year called "Turning the Tide Against Cholera." These are the Sonderbonds, the mangrove swamps where cholera has allegedly arose. And the small print says a global pandemic rose from these swamps. Now scientists may have a way to stop it, namely vaccine. But there actually is a small chink in the armor of this vaccine. This comes from the same trial done here in Calcutta, showing age-specific protection, and shows that if you vaccinate 1 to 4-year-olds, protection is lower than the protection is in older children and adults, and actually the duration of protection is also less. So this needs to be improved. The question is, how can we augment this protection in children? Well, one can take the usual vaccinology approach of changes in composition, formulation, presentation, adding adjuvants, and so forth. But actually, there are non-traditional ways that we can consider improving protection in kids. One is simply water, sanitation, and hygiene, provision of clean water, adequate sanitation, and providing adequate personal and food hygiene. Now, you might say, well, this might protect against cholera, but why should it actually improve vaccine performance? And the reason is that protection against cholera is what immunologists call leaky protection. Namely, it's not all or none. It can be overcome by higher and higher inoculi. And the combination of wash and vaccination is predicted, given this leaky immunological relationship, to be synergistic. Wash preventing cholera itself, but also improving vaccine performance. And this is illustrated on this hypothetical slide of a dose response, persons ingesting higher and higher doses of Vibrios. The y-axis is the probability of getting sick given that dose. The top line is a non-vaccinated person. The bottom dotted line is a vaccinated person. The action of wash is simply to reduce the frequency or inoculum swallowed, moving the probability from A to B. The effect of vaccination per se is to reduce the probability of disease at any ingested inoculum, moving from A to C. But of course, the combination moves from A to D. And indeed, ecological analyses have shown, not surprisingly, that if you plot use of safe drinking water on the y-axis, use of basic sanitation on the x-axis, and plot countries and then color them as to whether they are cholera countries in yellow or non-cholera in blue, unsurprisingly, there is a strong association between not having cholera and water and sanitation. To date, there's only been one formal randomized trial to evaluate this possibility. This was done by Firdousi Qadri at the icddr in Mirpur, Dhaka, and reported in the Lancet a couple of years back. This was a 3-arm trial in which clusters were randomized to receive oral cholera vaccine by itself, oral cholera vaccine plus wash, or usual services. And you can see on these Kaplan-Meier curves that both the vaccine arms increased the time to cholera, the two top curves, but the curves didn't differ from one another, indicating that the wash that was delivered really did nothing to improve vaccine protection. But a later evaluation of the wash was that uptake of some elements of it, like chlorinated water, occurred only in 10% of the recipients. So this does not eliminate wash as a possibility. What about micronutrients? Micronutrients, several micronutrients are known to be immunomodulatory agents, especially vitamin A and zinc, and are used in practice in global health. What is the data on these agents? A randomized trial in Dhaka of vitamin A and zinc supplementation in 2 to 5-year-old Bangladeshi children showed that co-administration of zinc for 3 weeks before the first dose of Holmgren's vaccine, Diarrhoeal, resulted in a modest increase in serum vibricidal antibodies. However, the zinc actually resulted in a slight reduction of antibodies to the B subunit of that vaccine. And an additional randomized controlled trial done in Dhaka in slightly younger children, 6 to 18-month-old kids, showed that zinc supplementation augmented vibricidal responses. So zinc actually is a possibility. What about breastfeeding? Well, as you may know, breastfeeding is one of the most potent protective agents against cholera in kids. This is a case control study that I did many years ago in Matlab, Bangladesh, comparing kids with cholera versus kids without cholera at separate ages and giving matched odds ratios. You can think of 1 minus these odds ratios times 100% as protective efficacy, so that at 6 to 11 months, an odds ratio of 0 meant it was 100% protective, but it was actually protective at all ages, presumably due to exclusion of ingestion of pathogens, but also to the immune and non-immune properties of breast milk. Well, the reason this may be relevant is it's conceivable that breastfeeding may actually inhibit immune responses to the vaccine in children. This was tested by Firdousi Qadri and Anne-Marie Svennerholm in Dhaka, showing that withholding breastfeeding for 3 hours before dosing augmented serum vibricidal responses, but only in one subgroup. I might add here that serum vibricidal antibody responses, although not true correlates of vaccine protection, are the closest thing to it that we have. Well, what about microbiota? I mean, that's what we're all here to hear about. There is evidence that the gut microbiome does influence susceptibility to cholera. Workers from Harvard and the icddr contrasted Bangladeshi household contacts of cholera cases for those becoming infected versus those who did not, used machine learning, the fad of the day, to construct a predictive model of susceptibility, including several variables, including baseline gut microbiota measured in stool. The model, in fact, picked out 100 bacterial taxa in the stool that were predictive. A particularly noteworthy association was the susceptibility was associated with depleted levels of Bacteroidetes and with increased Pericoccus aminovirans, which also promoted cholera growth in vitro. Another study recently published in Nature, also by workers at the icddr and Washington University in St. Louis, in a time series analysis of recovery of cholera patients, showed that the sequence of bacterial taxa during recovery resembled actually the sequence one sees in normal maturation of the infant gut microbiota. They then introduced into gnotobiotic mice species that correlated with recovery from cholera, and found that one species, Ruminococcus obium, restricted colonization by Vibrio cholera 01 in co-colonization studies. So there is evidence that the microbiome is related to susceptibility and recovery. Is there a relationship with vaccine performance? Well, several of the studies of this topic actually come from the live oral vaccine, CVD103HGR, genetically attenuated Vibrio cholera 01 that is given in a single dose, but is only currently licensed for travelers in the United States. A study when this vaccine was given to Chilean children showed that small bowel overgrowth, as measured by lactulose breath tests, was associated with diminished serum vibricidal responses. Helicobacter pylori, at least in very young children, in Chilean children, was associated as well with lower responses, primarily because the acute gastritis by Helicobacter actually increases gastric acid output and diminished passage of this vaccine, a live vaccine, through the stomach. And worms may play a role, again, with this vaccine. Albendazole treatment of Ecuadorian children infected with Ascaris enhanced serum antibody responses to the single dose. But the vaccines we're really talking about here are killed vaccines, not live vaccines. And the question is, is there a relationship between gut microbial profiles and immune responses to currently available killed whole cell vaccines like Scheinkohl? Actually, there's only one study thus far, and it was presented just about 6 weeks ago at the American Society for Tropical Medicine and Hygiene. It's not yet published, but the abstract by Anna Weil at the Mass General Hospital, working with our group at icddr and using 16S ribosomal RNA profiling before and after 2 doses of Scheinkohl, showed that the speed and magnitude of vibricidal antibodies were indeed correlated with a greater prevalence of Prevotella bacteria. This brings us inevitably to probiotics. What are the data on probiotics and vaccine responses? Well, these have been reviewed in a systematic review by Zimmerman and colleagues in a recent article in Vaccine. This is a systematic review of prospective controlled trials of probiotics given in conjunction with vaccines to augment humoral responses, 26 studies, 17 vaccines, and there was evidence for microbiome-related enhancement of immune responses, or I should say probiotic-related enhancement of immune responses in about half the studies. And the evidence was strongest for oral vaccines and for influenza vaccine given to the elderly. Well, do we have any data on probiotics and killed oral cholera vaccines. Unfortunately, there's very little data, and this is really an area I think that deserves future research. One conducted in Dhaka, Bangladesh, looked at children 2 to 5 years of age and tested whether co-administration of Bifidobacterium brevi at 4 times 10 to the 9th CFU per day enhanced responses. In fact, in this study, responses were not. Serum vibrocell antibodies were not, but this is simply one study, one strain. Another more ambitious study actually tested Diarrhoeal, the homegrown vaccine, with 7 different Bifidobacterium and Lactobacillus strains in French adults, very small numbers in each group. As you can see, 83 adults randomized to 8 groups. There was significant enhancement of responses to 2 of the groups. So in summary, cholera remains a global public health problem, especially in populations in lower and middle income countries and populations made vulnerable by natural or man-made disasters. Inactivated oral cholera vaccines have been game changers in efforts to control cholera and are now stockpiled for use in emergencies and in endemic settings. And I think the world really has to thank your own NICET and the people of Calcutta for generating the absolutely critical evidence that has led to this sea change in global efforts. However, the efficacy of these vaccines is lower in children, and to improve this protection, several non-traditional, that is non-vaccine approaches may be considered. Improved wash should theoretically improve protection, but the only trial to test this in Dhaka yielded somewhat disappointing results, primarily because of inadequately implemented wash. Co-administration of zinc and temporary cessation of breastfeeding at the time of dosing showed some improvement. And although the gut microbiome has been demonstrated to influence susceptibility to and recovery from cholera, and appears to be associated with immune responses to killed oral cholera vaccines, co-administration of probiotics hasn't shown a great deal of benefit, but these studies are very limited and really require further research. Thank you very much.